Hello and welcome everybody to another exciting episode of Side Talks 2.0. As always, my name is Dr. Jack Saxenian. And today I have once again a guest, Dr. Priewe Soni, here to talk about some of the developments since our last episode on the coronavirus. She will talk to us about some of the changes that have taken place, some of the advances in terms of data that we've gathered, and what to expect and what to sort of keep in mind going forward. So as many of you had really liked her presentation last time, she is willing to continue doing these episodes with us to keep informing you about the right data and the right information to be paying attention to. So with that, Dr. Soni, I want to leave it up to you. Maybe quickly say a couple of things about yourself once again for those audiences that may be new to this show and are seeing it for the first time, and then we can start discussing about the topics that will be.
Thank you so much, Jacob. Again, my name is Dr. Priewe Soni. I'm an assistant professor of pediatric infectious diseases, and I've been following this outbreak and pandemic now very closely, and we hope to have some good discussion for you guys that hopefully gives you the facts and in the same time keeps you remaining calm, hopefully, about this whole evolution of everything. It feels like it's been like a year since we've talked last, but we actually just had a little talk a week ago, and so much has evolved and changed since then. And we just want to keep you up to speed with all of the changes from a clinical standpoint and some of the interesting research that's coming out, even faster than we can read it.
Awesome. So the way I want to kind of shape this is we'll talk about some of the good stuff in terms of developments in the drug world and things that we could be using to fight the infections, and then going into a little bit about the bad stuff, about things to watch out for, and finally, hopefully, we can end it with some more note. So on that, can you tell us about some of the work and the research that has come out recently about a couple of promising drugs that are in development to target the virus and prevent its spread and infection?
So there are many different therapeutic options that have come to the forefront with this rapidly evolving situation. So one of which is something that I talked about last time, which was remdesivir. Remdesivir is an antiviral agent that was previously used, thought to have some activity against HIV. But when they studied it, it also has effect against certain coronaviruses like SARS and MERS. And that's why scientists have decided to move forward with using it in this specific case for SARS-CoV-2 causing COVID-19. So there are actually phase 3 trials that are already in place for this drug. On the large part, it is available for compassionate use through the pharmaceutical company in cases that are very, very severe. And some of the preliminary data is promising with use of this early on. However, there are some other agents that have come up over the last week or so, and two of them are sort of the same. They're essentially the same, hydroxychloroquine and chloroquine. So there was a great in vitro mouse model study came out of China that showed that this drug that we really use chloroquine for malaria and other intracellular organisms. We use hydroxychloroquine in this country for Q fever caused by Coxiella burnetii. So these two agents have activity for intracellular pathogens, but what we're finding is how it works in a virus is that it causes alkalinization of the phagosome inside the cell, and that is thought to inhibit the viral replication. In addition to that, it does have some other anti-inflammatory properties, which we're still trying to tease out and figure out. So I think those are some promising agents that we'll be watching for. But of course, there are other things that could be possible benefits to combating some of the long-term complications of this virus. including the inflammation cascade that gets activated in ARDS in some of the complicated cases. So there's some thought that an anti-IL-6 receptor inhibitor could be helpful in some of those severe ARDS cases, but that is also still, we still need time to flesh that all out.
So these are exciting sort of advances because on the one hand, we want to find ways to sort of prevent the spread of the virus, but that's almost inevitable. So having some form of targetable drugs could help with slowing it down and at least giving clinicians enough time to come up with some other solutions and also potentially a vaccine in the not
Yeah.
too distant future.
Yeah, I think I just wanted to mention, we did start on Monday, the 16th, the first phase 1 trial for a new therapeutic vaccine for COVID-19. And we are enrolling, NIH is enrolling healthy participants age 18 to 55 to get this vaccine. And there will be a couple doses. So a dose at day 0 followed by day 28, and I believe there's one additional dose that they're going to be seeing, and they'll be studying the immunological sort of immunogenicity of that vaccine in healthy adults before we move on to phase 2 and 3 trials. So it's amazing actually that the NIH was able to use this vaccine that was initially developed for SARS and MERS to be used in this setting too, and for it to be so rapidly implemented in a phase 1 trial. I've never seen any vaccine trial get initiated with such speed. So it's quite remarkable and promising. Keep in mind, it will be at least 12 months before we see a commercially available vaccine for COVID-19, but at least it's a start. So I think that's a positive note as well.
That's exciting. And, I also, like you're saying, we got to move with optimism, but with caution as well, because we got to make sure that these vaccine developments are not done too hastily and we end up developing things and to people that causes more harm than good. So some people are saying, well, why is it taking so long for these vaccines to develop? Why can't we just start injecting them? And so it takes, time to actually make sure it's not hurting before we start seeing its efficacy. So I think we need to be patient, but at the same time, keep hopeful optimism on this. And hopefully with the other 2 drugs you're saying, it could buy us enough time for the vaccine to be developed.
Absolutely. And I mean, I didn't even touch about some of the other options, from those that have survived, that developed higher antibody levels. That could be a possible therapeutic option as well. So there's so many different modalities that scientists are working on simultaneously for this. So I think that's really, really promising in a week of what feels like just total doom and gloom. That's definitely a silver lining.
Yeah, I absolutely agree. I think the pace and the rapid speed at which these things are being developed, I think, shows also how humans could come together to do great things, but also should give people more optimism and a better outlook of what's going to happen. It's not, as you're saying, doom and gloom that most people are feeling. Now, can we talk about a little bit more about some of the more difficult situations in terms of,
Yeah.
as a clinician, what are some of the issues that you are coming across as an infectious disease doctor in terms of the logistics of how this pandemic is being sort of handled on various levels of um, uh, uh, authority, let's just say?
Yeah, absolutely. I mean, I think um, I speak for all of my colleagues in that this has been one of the most difficult weeks. All across the country, you guys have probably been following just the rapid increase in positives, as well as many patients who have died. But it's still, this is something that we expected, right? Because we're hitting that really steep part of the exponential curve as we are having more testing available in different parts of the country. So the top 3 states right now that are being that we're seeing the more positive cases is Washington State, New York, followed by California. Um, that being said, we still have some time before it feels like it's going to get a little bit worse, as the numbers of cases are going to continue to multiply and sort of exponentially grow. We are about 2 weeks beyond or 2 weeks behind what Italy is facing currently. So that is why social distancing is so important at this moment. Really and truly, this will sort of flatten the curve, as you've been hearing, and make a big impact on the amount of ventilators that we're using on high risk ICU patients, and not create a surge that would overwhelm all of our hospitals. We hope that that doesn't happen, but I can tell you from ground zero right now, I'm starting to get nervous, but I'm trying to stay hopeful. And all of our teams, spoken to many other hospitals, and we're sort of ramping up. We're learning from other hospitals. I think one of the most beautiful things is I've seen so much collaboration amongst physicians from different hospitals and states, and kind of learning from experiences in other places where they have been hit harder, whether it's an outbreak in a skilled nursing facility or other community spread that we're seeing a little bit more. I think one of the main points is that we need to start normalizing this. Everything is still sort of unknown and new and novel, but we have to start normalizing this, as COVID-19 is going to be, unfortunately, a part of our lives, and we will get through this, but it may get a little bit worse before it gets better. And then in the winter, again, we may be facing the same issue, but we'll be better equipped to handle it by that point.
So in other words, people should be mentally preparing themselves for the long haul, right? Although, most people are saying, oh, 2 weeks, I'm going to get ready for 2 weeks. Kids are going to be able to go back to school. So I think that's sort of misleading. It's not like the virus says it's been 2 weeks, I got to leave here. It's more like we're looking into August, September, before things start to maybe dip towards the right direction. And
Yeah.
so they need to be prepared, not just stock up for food, but be mentally and physically prepared.
Be mentally and physically prepared. And one of the main things I can say is, this is a time for people in medicine to really show leadership, because people are looking to you to see what kind of behavior you, as a leader, exhibit in times of stress and anxiety. So you have to be a good example for other people around you. And I really stress that to my colleagues as much as I can. We have to move forward with this and, do the right things, but that doesn't mean you have to do them in fear. You just have to take it one step at a time.
So I know we discussed a little bit last episode, but I think we can't say this enough. What are the right things people should be doing, right? Washing their hands, covering their mouth with their elbow when they're sneezing or coughing. What are the other things that they should be doing with the, quarantine and just the behavioral stuff?
Yeah, right now the government has sort of laid out recommendations for not meeting in groups more than 10 to 25. It's not so much the number that matters, it's just you shouldn't be in close contact with a large group of people where you're going to have a higher likelihood of being in contact with someone that's infected. We still don't know about transmissibility in that asymptomatic period where people don't necessarily have a fever yet, but still could be shedding virus and causing more infection to others, especially our vulnerable hosts. We know that patients above 65, particularly above 80, are being really, really hardly hit by this, but it's your job, if you're healthy, 20 to 50-year-old, to prevent those vulnerable populations from getting hit harder by just socially distancing and remaining at home if you can. I mean, no one's saying that you can't go out for a walk, or that sort of thing, but really limiting those big group gatherings is going to be very important. And we won't see the impact of those social distancing effects until 2, 3, 4 weeks down the road. So what we do now is extremely critical in what we're going to be seeing, and how our healthcare systems could be strained by this. So please, I urge all of you to keep that in mind for all of us that are here in the hospital dealing with this.
So I know people have probably heard of the flattening the curve, and you've eloquently mentioned things that can be used to flatten the curve, and they've probably read it. But can we discuss a little bit about what it actually means in terms of flattening the curve and the impact it has on the healthcare system, and why doing these things on a global level is important, not just for them individually or their immediate friend or family member, but on a population level, why each of our behaviors can have a sort of trickle down effect on everybody around us.
Absolutely. So I kind of touched on this a little bit, but in order for us, as you know, we have a certain amount so we know that the patients that are getting this infection that have really bad outcomes and that are in the ICU, that are intubated, sometimes they're intubated for weeks on end. We have a certain amount of ventilators available in this country. I believe about 65,000. You know, if we continue to go along the curve without social distancing, we would hit that maximum and really see a situation that we're seeing in some of our other countries around the world, where we're having ventilator shortages and we're having to make very difficult decisions as clinicians based on who needs to be vented and who we don't vent. And that is just that sort of decision making is what we're trying to avoid. And so really by staying at home, you are limiting your interactions with people. You have to, until we have testing widespread, I say that you sort of have to treat everyone you meet as someone that could be possibly infected by this, right? Until we get to the point where testing is just like everybody can get it, even if you're asymptomatic, we have to kind of be cautious and be mindful that really and truly flattening that curve by staying at home is going to impact the people that are on the front lines the most, and then in turn, the outcomes of those really, really high at risk of dying from this. So I hope that explains a little bit more. But
Yeah, no, I mean, I think that's a great explanation. And yes, people like the flattening the curve will have major impact on the amount of people that could be treated at any one point. So do think about those that will eventually need ventilators. And I don't think anybody's going to sugarcoat that and say, well, hopefully we're not going to be different. We're going to be different than other countries, but we're not. We're going to reach those numbers eventually. But if we could do it at a very slow pace where the hospital systems can sort of absorb all of those patients, then we will have much, much better outcomes in terms of mortality.
yeah, and many hospitals are preparing for that surge in case all of the implementation of social distancing doesn't work, you know. So we are preparing for that surge, but we don't want to have to get there. We're trying to buy time and buy time to getting to that point where everything is saturated. And one of the things that I also wanted to mention is that early intubation we know helps in patients that are positive for COVID-19. Early intubation is one of the major supportive treatments. So it's not like, you know, we want to be able to offer that to anybody who's at a really high risk of decompensation from this virus.
So, you know, these are important issues. And going along with that, you know, testing has been an issue in this country. What are some of the strategies do you think can be helpful in sort of combating that major hurdle to get the testing to be more widely used and actually getting testing done and the kids ready for it?
Yeah. So basically, I wanted to mention that our approach to getting testing out could have been done a little bit differently. You know, hindsight is always 2020, but if we were to ever face this sort of situation, my thoughts are that initially we went for a linear approach, right? So CDC wanted to create their own testing first, which would be validated by them and then distributed to local and state governments. That linear approach is what really might have caused us to get a little bit behind with this. If we had done more of a shotgun approach in the beginning, anticipating that this is going to develop rapidly into more of a widespread pandemic and epidemic within our country, getting commercial labs and research labs on board early on, and then having CDC validate those lab tests from many different sources, maybe we wouldn't be in this spot now. But at this moment, I know that state governments are providing testing, but two commercially available labs, Quest and LabCorp, also have testing, but they are getting saturated, as you can imagine. Everybody wants their tests sent to these commercially available labs, and they only have the throughput to handle and the manpower to handle, 1,000 some samples, and they're getting, 5,000 samples a day. And so they're having to freeze a lot of their samples of the respiratory specimens for extraction of DNA later on. So the turnaround time is getting to be a rate limiting factor. So we're not able to identify who's positive as soon as we want to, and in turn, fully isolate them in a way that they're not continuing to spread to others. So that's a problem, but I hope by next week we will have other commercially available platforms at our disposal and easier methods for testing. So right now we're having to test by having either an ambulatory provider do the swab themselves, or the patient meets criteria for testing within our emergency departments or the floor. And that's a really big rate limiting factor right now.
So what's testing being, who is the testing being limited to at this moment in terms of the people that are getting tested? What's the criteria for saying you're going to get the test? Because
well, I think it varies by institution. And so these are some of the decisions that we're having to make based on our, the community spread of the virus in our particular areas around the nation. So I can't speak to everyone, but we all each have pretty much our own algorithms for testing. And at the moment, I know that widespread testing for asymptomatic people is not available nor recommended. We really want to save testing for those that have the epidemiological risk factors of this infection. So travel to those higher risk countries that we're seeing widespread infection in within the last 14 days, as well as those who have a contact that was positive for COVID-19 in the last 10 to 14 days, and healthcare workers. So that's a big, big thing, right? So we don't want half of our healthcare workers to be out and quarantined. So we really need to make sure that testing is streamlined and available for them so that they're able to be on the front lines to care for these patients.
So I think hopefully in the next week or so, these limiting factors could be addressed with, I know there are some suggestions about getting the Army Corps engineers to come in and start building some of these tests. So hopefully the government does something more proactive and aggressive to be able to give us the tools to do the right medicine. Now, in speaking of medicine, I know there was an exciting study looking at one of the most important drug targets that we know as physicians, which is angiotensin converting enzyme receptor, and how people who have differences in this could actually have differences in susceptibility. This has made a lot of news. Can we maybe touch upon that just a little bit? Because I think it's an important topic, and in terms of susceptibility and also potentially drug target.
Absolutely. So this is really interesting, and it has the scientific community a little bit split. So basically, to understand this, I'll explain to you that the outside of the coronavirus is covered with what we call like a spike protein, and that's what gives it the name coronavirus, which means crown, right? So in order for the virus to get into our cells, it requires this ACE2 receptor. So the virus essentially has to bind to that receptor and then allow it to go inside and hijack our, utilize our cells' components to replicate, right? So that ACE2 receptor is found primarily in your mouth and then also in the lower parts of your lung. And there are patients that are getting more hit by this virus, right? So one of the stratifiers for mortality is hypertension. A lot of patients that have cardiovascular disease, hypertension, are on what we call ARBs, or angiotensin receptor blockers. So basically, they have increased expression of these receptors on their cells, and also patients that are on ACE inhibitors too. So those patients that are taking that medication for hypertensive purposes, the thought is they're expressing more of those ACE2 receptors on the cell, and in turn, the virus is able to hijack those cells and those patients a little bit more readily and cause more rapid infection and higher rates of mortality. So it's interesting because, you know, hypertensive and cardiovascular disease patients aren't the only one to take ACE inhibitors, for example. Diabetics too take it to prevent kidney injury. So these medications in itself have anti-inflammatory properties, but what is being brought to the table now in the Lancet article that you're referring to, I think the Lancet article says that, you know, could those patients be at higher risk of more severe infection just because of the medications they're taking? By no means do we recommend at this moment stopping those medications if you happen to be on them. I think that's really, really important for me to say here is like, there's no data to suggest stopping it will prevent you from having a bad outcome in COVID-19, but I think it's an interesting piece of this puzzle that we're going to have to delve into as scientists to tease out really what's going on with that.
So this is kind of a double whammy, right? Because people that have these comorbidities are already high susceptibility to being sicker, and now because of the drugs that they're taking, it makes it even worse. So it's like the effect is compounded by
Exactly,
this
and those are
situation,
they're also older people that are taking these medications
right?
too. So, and then combine that with in older adults, we see something called immune senescence, where your immune system sort of dampens and the response to pathogens is a little bit more blunted. You combine all of those factors, you know, I think that can explain a little bit more why we're seeing worse outcomes in these higher risk populations.
Now, to go to the other extreme of the age group, people, newborns or the ones that are not born yet, I know I have some friends who are currently pregnant, and I'm sure life will continue like normal and people will get pregnant. The question is this virus transmissible during pregnancy, and should the mothers and the family be worried about the, the transmission via the placenta or during pregnancy in any form? Are there any data showing one way or another?
So I'm a pediatrician, so I'm also particularly interested in this. So just recently, a few days ago, a study came out. It was a case series from China that reports that there were about 4 women that um, acquired this infection in the 3rd trimester who did not transmit to their babies and newborns after delivery. They were separated after delivery. I believe 3 out of 4 of them had C-sections. However, the children did not develop any respiratory symptoms, nor in routine sort of screening for the virus, they did not develop this virus. Now, we still have to kind of see whether the virus is being shed in other parts, amniotic fluid and things like that. But this was probably one of the better news that I heard this week, and I just wanted to share that, but more to come. But I think this is um, a good thing, a good, I guess, study that I could offer to my pregnant friends and those that are thinking of getting pregnant in the future.
So this is exciting. I mean, this is like you're saying, it's really a good news because you know, people that are currently pregnant can continue having their pregnancy as usual and not, at least with that study, worry about anything else. Are there any other exciting studies that you've come across in terms of pertaining to people directly in in this sort of difficult situations?
I think there are so many things that I've been reading recently. One of the main things that I want to sort of relay, if I can end on this, is that this is a virus that's sort of has a lipid envelope, right? So some of the behaviors I'm seeing are very interesting because people are going overboard with the cleaning and sanitizing and things like that. So I just want to relay actually, not anything, not a research study, but just the fact that this is a lipid envelope virus. So it is really easily killed with plain old soap and water. We don't need to be, you know, going crazy with Clorox and things like that. It's always good to wipe down surfaces in the bathrooms and things like that, but good old washing your hands is going to go a really, really long way in just denaturing the virus and killing it completely. So I did want to relay that. And then there's going to be some studies coming out about how long this virus is viable on fomites or inanimate objects. And one of the things that I found interesting is that, you know, you can't transmit the virus through clothing or more porous substances or surfaces rather. It's more of the hard surfaces that it tends to lie dormant on and, you know, be viable for transmission. But just cleaning surfaces with soap and water is also very effective in preventing that sort of spread through fomites. So that's just an interesting tidbit that I wanted to leave you all with. And
That's a great piece of advice because I'm getting that question a lot, and also, you know, the good and then soap method is the best. You know, washing it with the soap is the best way. Well, it's been wonderful again having you. I can't thank you enough for doing this and coming on and being able to share your knowledge and wisdom, and also uh, diverting people to the right information and what they should be paying attention to. So hopefully we'll continue doing this on a weekly basis and keep updating people as things change. And as you said, this is so rapidly changing that come next week we might be discussing something hopefully optimistic.
hopefully optimistic. Yeah. And I just, you know, everybody's in survival mode right now. Your instincts come out like that when you're faced with something that is unknown. And that brings up a lot of fear and anxiety. But we just have to take it one step at a time and look at the information and not be so brainwashed with some of the scary news that we're constantly being bombarded with, being really conscious about the amount of time you're exposed to the media and setting limits for yourself and your own personal anxiety. So I think that's really, really important and crucial, and I'm happy to help and to speak with you guys and hopefully allay some of your fears and anxieties.
You've done a great job with doing that. So I want to thank you and want to wish you a wonderful rest of your day, and we'll see you in the near future again. So
Yep, see you soon. Have a great
have a
week.
good one. You too.